Oh, also Zoom lags the YouTube comments. So if you ask a question and it'll take like around 30 seconds.
Okay. Yeah, that's fine. I'll just give it some time for anybody to answer.
Oh, also,
Yeah, so if there's not any responses yet, it's just that it hasn't gone over.
we're
Okay.
live.
Okay.
Good evening, web chatterers. We would like to thank you all for attending our session this evening. Today, we have the pleasure of hosting Dr. Baig, a radiology resident.
As always, please remember that the Google form will be posted in the comments and on our Instagram bio at the end. With that being said, Dr. Baig, you may start whenever you're ready.
All right. Thanks, guys. First off, thank you very much for having me on. Just a shout out to you guys for putting this together. One thing that is really cool and inspiring is that, even through this pandemic that we're dealing with, you guys found a way to be kind of innovative and kind of come up with a way that people can still learn, still, hear about cases from doctors. So kudos to you guys for putting this together. So this session is going to be, about radiology. I'm going to talk initially about kind of what is radiology, what does it entail, and then we're going to go through a case presentation. And if you have, any questions at any point, you can type them into YouTube or wherever you're streaming, and eventually it'll get to me somehow. All right. So without further ado, all right, let's get started. Okay. So what exactly is radiology? It's something that we hear about, but I guess it would be good to kind of define it. So I went on Wikipedia and I typed in radiology into Google and I took the definition of Wikipedia, and they said the medical discipline that uses medical imaging to diagnose and treat diseases within the bodies of animals, including humans. All right. So what exactly does that mean? So radiology is a field where you're using imaging. And when we say imaging, we mean x-rays, CT scans or CAT scans, MRIs, things like nuclear medicine as well, ultrasound as well, where we're kind of sometimes doing these studies and sometimes, not sometimes, but all the time, interpreting these studies. What does that mean? That means that when you go get an x-ray, the person that tells you whether, you have, a fracture or not, or, whether when you get an MRI, if they tell you like, oh, if you have some injury in your knee, right? Like, anybody that's a sports fan, if you're a Giants fan, Saquon Barkley just tore his ACL. The doctor that basically looks at these images and tells patients, what's wrong or what the diagnosis is, that is what a radiologist does. Okay. I put up some graphics to make it a little less dry. But this person right here, and I just Googled radiology and this is what came up. So what's going on here is that this is basically a CT scan. And we'll go over that in a little bit, but what you'll notice is that you have these special monitors, and that's something that happens in radiology where basically you work a lot with technology, you work a lot with really kind of expensive equipment. These monitors, if you look them up, I think the cheapest one goes for like $10,000 or $15,000, and most of them go for around $20,000 to $30,000. So these monitors that we use, they're kind of specifically designed for radiology. They're really high resolution. You can really see things super clear. And then this right here, basically, whenever you get any kind of what we call cross-sectional imaging, and when we say cross-sectional, it basically means like a cross-section of your body. That's referring to CT scans or MRIs, okay? And without going too far into details, I'm just gonna quickly break down what is what, and what kind of imaging is included within radiology, right? So we all know what x-rays are, right? X-rays are basically, it's radiation, a small amount of radiation that goes through your body, and depending on which part of the body it goes through, that's what's going to be imaged. So over here, right, what we're looking at is we're basically looking at a knee, right? And this is an x-ray of a knee. Over here, what we're looking at, and you can kind of make this out, It's the side view or the lateral projection of a skull and the neck, which, here we call it the cervical spine. Okay. But these are x-rays. Okay. Now there's something else that I was speaking about called a CT scan or a CAT scan. I'm sure you guys have heard of it. And this right here is a CT scan of the brain. Okay. Now, what exactly is a CT scan? A CT scan is very similar to an X-ray in the sense that it is radiation, and it's going through your body, but it's much stronger than an X-ray, and you're able to see different shades of gray. An X-ray, you're a little bit limited. X-rays are fine for bones. They're quick. They're cheap. CT scans are a little bit more expensive. They're still relatively quick. You can get a CT done in 2 to 3 minutes, but it gives you a whole lot more information. The downside to it is, you are being exposed to a little bit more radiation. Okay, and we'll go over that in a little bit further detail in a bit. And then this right here is an MRI. An MRI is basically a machine that also takes cross sections. So if you imagined, taking a picture, like we're looking at brains here, right? What you're doing is you're looking at cuts of the brain, basically kind of going down like this. We call this the axial view. It's almost like you took an axe and you were cutting through someone's head. I don't endorse these kinds of things, but just to make it an easier explanation, that's what the axial view means. And what we're doing is we're basically getting sections, right? We're basically getting thin slices, right? And we're kind of getting a whole picture of the whole head. Right. And you can do this with any part of the body. But an MRI, what it does is it uses magnets. It uses magnets to make the image. And I'm not going to go too far into the physics. But let's see. There is. Oh, a lot of students are concerned about your battery. Yes, that is a good point. I will plug in, but I want to get through a little bit more because I want to give you guys a little bit of a break. So we'll do that in about 5-10 minutes. Okay. All right. So within radiology, there's two parts of radiology. One is diagnostic radiology and one is interventional radiology. Okay. Diagnostic radiology is what I was just talking about. That's, looking at x-rays, looking at CT scans, looking at MRIs, giving people diagnoses, right? When let's say, God forbid you have abdominal pain, right? You have a pain in your belly, right? And they go and get a CT scan. That's a radiologist that's going to be reading it and telling you, do you have appendicitis? Do you not have appendicitis? Do you have something going on with your intestines? Do you not have something going on with your intestines? That's a radiologist, right? That's more so along the lines of diagnostic radiology. What is interventional radiology? Interventional radiology, the definition is a medical subspecialty that performs various minimally invasive procedures using medical imaging guidance such as X-ray, fluoroscopy, CT, MRI, and ultrasound. IR performs both diagnostic and therapeutic procedures through very small incisions or body orifices. Basically, that's a very fancy way of saying it's basically minimally invasive procedures. Now, what exactly does that mean? In IR, we don't make, big cuts that you see, in surgery or anything like that. We're not, doing anything that's going to cause you like a long recovery time. Most of the things that we do are either we don't even need to make an incision where we're kind of just using a needle and accessing, either your vein or your artery, and then using the body's kind of highway of veins and arteries to get to where we need to. Or if we do have to use, an incision, it's usually a very small incision. And the way that we're able to do this is, the body is a beautiful thing in that everything is connected. Your veins will lead back to your heart eventually. And your arteries also, they kind of go all around your body. So if you are able to access kind of the arteries or the veins, you can really get to pretty much most parts of the body. Now, if there's something that requires surgery, right, that's not something that interventional radiology would do. Like, for example, right, if somebody is, coming to the ED as like a trauma, God forbid they're in like a very bad, car accident and, they're bleeding from within their abdomen and they have intestinal injury. That's something that would be more reserved for surgery because that's something where you can't really do that minimally invasive. But for everything that you can do minimally invasive, That's where interventional radiology comes in. Okay. And when you work in interventional radiology, this is basically kind of a room that you would be working in. What we have here is, we call this a fluoroscopy machine. This is basically like an x-ray machine. It's a mobile x-ray machine. And, you know, as we're working, and this is kind of like, it's a lot of hand-eye coordination. You know, as we're working, we're kind of seeing, like you can see on the screen, like you're looking at what you're doing as you're doing it. Okay. And we do this not just with fluoroscopy, but with ultrasound as well. You know, whenever we do biopsies, a lot of times, you know, if there's concern, if somebody has cancer or something like that, right? What do you have to do? You have to get a little piece of the tissue, and then you look at it closely to see if it actually is cancer. But in order to get a little piece, you need to look at it under ultrasound guidance, and you go in with the needle. That's all interventional radiology. Okay. And I'm not going to go into it too, you know, I know I already spoke about it so much, but I'm not going to go too far into it, because this is a little bit more, you know, about radiology in general. But we could always do an interventional radiology thing, you know, later on, because that is one of my, you know, passions, and that is what I'm going to be going to. Okay. Let's see. Okay. So, question: does a scan have to be sent to a radiologist to be confirmed, or can an internist, etc., read them for confirmation? So that's a really good question. So many times what happens is, you know, radiology is not the only field that can read these images. So for example, if you get a chest x-ray, many times the ICU, they'll take a quick look at it too. They're usually okay at reading them. And sometimes they will go and start doing things based on what they see. But ultimately, at the end of the day, every single scan, whether it's X-ray, CT, MRI, ultrasound, it needs a radiology read. And the reason is, we train in this. We train for 4 years as residents, then we do a fellowship for another year, and then we become attendings. But throughout these 4 years, like, we're basically seeing all kinds of cases. And because of that, yes, other fields can look at imaging and they can get a general idea, but it's one of those things where, like, you know, if you needed something done for your lungs, right, you could go to an internist, and they might be able to kind of, you know, look at the basics and kind of help you out that way. But there are certain things that the internal medicine doctor may say, you know what, I'm going to defer to the pulmonologist, because the pulmonologist is the expert in lungs. The same way, you know, the ED, internal medicine, surgery, you know, they all look at the imaging. It's not that they don't look at it. And the basics they understand, and they'll be able to, you know, kind of work based on that. But at the end of the day, they will defer to us in terms of, all right, these guys are the experts in the imaging, and whatever they say is going to dictate kind of how we treat this patient. Okay, so to answer your question, yes, every study does need a radiologist. You need a read from a radiologist. Okay. And there was another question. Okay. One other question. Does a radiologist do the incisions themselves, or do you have other surgeons help with that? Okay. You want me to make it full screen? We'll make it full screen. No problem. All right. Help me out, guys. I usually do it on PowerPoint, but probably view full screen, right? There we go. Okay. All right. That did. Okay. View present. Okay. Man, I promise I'm not a boomer, but right now I'm definitely acting like one. Hold on 1 second. All right, so I lost the, yeah, I know, but I lost the top part of it. Let me see if I can, yeah, let me hit escape. There we go. There we go. All right, so we'll go to view and then present. Okay. Okay, awesome. All right, sorry about that, guys. All right. Now, okay, does the radiologist do the incisions themselves, or do you have other surgeons help with that? No, so we do everything, you know, in terms of interventional radiology. When we're, you know, doing a case, That's pretty much just us. Okay, perfect. And then I'll try to make this a little bit smaller, so it'll be out of the way. Okay. Yeah, so in interventional radiology, you know, we suture people if we need to. We make small incisions on our own. We'll go in with the needle on our own. You know, we don't really do anything with the surgeons. We have our own IR suite. We don't really go to the operating room unless sometimes they call us. You know, if they need help with something. And there are certain fields of surgery where we do work together. For example, vascular surgery, we will work together with them on what we call like peripheral arterial disease cases. So there is collaboration, but in terms of like, you know, making the incisions and everything, like, no, we're very comfortable with doing it on our own. Like for example, today, I'll just give you an example of kind of an easier case. It's called a PICC line, where basically you kind of put a long IV inside someone's arm. And the purpose of this is, it's many purposes, you know, to give antibiotics, to give fluids, everything like that. You know, I did the case pretty much, you know, all by myself, and, you know, there's no surgeon or anything like that. And that basically involved, you know, taking a needle, going right into the vein, making a small incision, you know, putting the tube in properly, you know, taking the wire out and everything, suturing it in. So, you know, it's basically minimally invasive procedures. Okay. All right. All right. So what does a typical day look like? And we're talking about specifically just any radiology resident. I'm not talking specifically about interventional radiology, because again, that's a little bit different and we can do that on a different day. But for a radiology resident, usually most programs will start either 7:30 or 8 in the morning. You know, you get in, you touch base with the night person. Usually there's one of the residents that, you know, comes in and works overnight. And when we say sign out, what we mean is, you know, they tell you if anything happened overnight that you should watch out for, or if there's any studies that are coming in close to 8 a.m., you know, you help them out with it. Okay. 8 a.m. to 9 a.m., something called protocoling studies. Now, what happens in radiology is you have to understand that every single field of medicine interacts with radiology. Every single field of medicine is kind of dependent on radiology. And I'm, you know, of course, obviously I'm a little bit biased because I'm in radiology, but you have to think about it this way, right? Like when would you go to a doctor and they wouldn't get an x-ray, you know, or a CT or an MRI? Like these days, pretty much anytime you go to a doctor and you say, listen, my arm really hurts or something like that, or, you know, I've been having this like kind of weird abdominal pain, I'd be willing to bet that your doctor would say, you know what? Okay, I'm gonna examine you. I'm gonna do a history on you, but I'm thinking it might be this. So let's get this imaging so we can get further clarification. I say all this to say, when we say protocol studies, what that means is oftentimes when doctors, when they want to get a study, they may not know exactly what study to get. For example, right? If someone is having abdominal pain, right? A doctor may be concerned about, let's say, appendicitis, right? Let's say they're worried about your appendix being, you know, inflamed. So there are many different imaging studies that you can get. You can get a CT scan, but even within a CT scan, there are many different studies that you can get. There's a CT scan with drinking oral contrast. Contrast is a dye that basically lights up whatever it touches. So oral contrast means the patient would drink the contrast and it would light up the stomach, you know, the inside of the stomach, the lumen of the stomach, the small bowel, and the colon, the inside of it, right? Now, do you want that, or do you want something called IV contrast, where basically you put an IV in the patient and then you inject contrast because you want to see the vasculature? So what we do during this time is we help out the clinicians, we help out internal medicine, we help out, you know, surgery and all the other departments in telling them like, okay, if you want to look for this thing, you should get this study. Right? If you're concerned about this diagnosis, this is the best imaging study to get. So we do that usually from 8 a.m. to 9 a.m. What we call protocol studies, meaning we will say, okay, For this study, do this. Okay. And at that time, you're also going to start reading. Now, when we say reading, what does that mean? That means that you start looking at the studies as the studies come in. You see an x-ray. Okay. You open it up, you look at it, right? It's a chest x-ray. I'm saying chest x-ray because we're going to go over chest x-rays, right? Chest x-ray. What are we looking for, right? Is it normal? Is it abnormal? If it's abnormal, what's going on, right? We dictate a report. So this is all part of reading, right? When we say reading imaging studies, that's what we mean. And at the end of, one study, what you have is you have a report with findings. And then at the bottom, you basically give kind of like a short summary. You say either normal or abnormal. And if it's abnormal, you give the findings. If you need to call somebody, you call somebody. Okay. And we do this basically throughout the day, usually from 8 a.m. to 12 p.m. You'll usually do this. And then usually most programs around noon, they'll have something called a noon conference. It's basically a lecture. Either your attendings will give you a lecture, or these days with COVID, we have a lot of like video lectures and everything. Okay. And then usually our day ends, depending on your program, usually around 4 or 5 p.m. That's when, you're going to kind of wrap up your day. You're going to try to finish reading all of the studies that are here, on your list. And then usually you go home. So it's not bad. Now there are certain things that I'm not going to go too far into because I do want to get to the case. But, if you're on call, obviously you're going to stay a little bit later. You're going to read more studies. And if you have any specific questions, feel free to ask. Okay. Okay. So we're going to go over normal chest x-ray anatomy in a second. Okay. But I want you guys to look at this and start familiarizing yourself with what it is. And notice right here, right? This says L. So this is the left side of the patient. This is the right side of the patient. And what you want to think about it is as if you are looking directly at the patient and the patient is looking at you. That's how you want to think about these chest x-rays. Okay. So why don't you guys take a look at that for a second, familiarize yourself a little bit. I'm going to get the charger. I'm going to plug in so that we don't die. Okay. I'll be right back. Okay. Okay, some good questions that we'll answer while we're, going through this chest X-ray anatomy. Can a radiologist have their own practice, or do they mainly work at hospitals and clinics? Actually, I don't know the percentage, but I think majority of radiologists actually work in private practice, meaning they will join like a private practice group, and they'll kind of do that. Or certain radiologists prefer working at hospitals. So you can do both. There are radiologists who actually start their own practices. It's a little bit more, I guess you could say, capital intensive because some of the machinery for, radiology is a little bit more expensive. But there definitely are people who are able to go into private practice, either start their own group or join a private group on their own. Okay, so you have both options. All right. Hardest body region to read a scan of. How do you know when a study should be ordered with, without, or with and without contrast? So I'll answer the first one. Hardest body region to read a scan of. I would say, I think MRIs in general are a little bit more kind of upper level imaging. I would say, some of those musculoskeletal imaging, you have to really kind of familiarize yourself with. So those can be a little bit challenging at first. And as you progress through your residency, you get better at MRIs, but it's definitely kind of, way more challenging than I would say X-rays and CTs. So I'd probably say MRs of maybe certain joints, would be a little bit more difficult. Okay. And how do you know when a study should be ordered with and without or without? So a lot of that, honestly, comes down to experience. As you get familiar with the diagnosis, and that's something about radiology, is that we're not in silos, in the sense that, like, yeah, our reading area may be separate, but we have to put everything together. Like, we have to think about, all right, like, what is going on with this patient, and what kind of imaging does this patient need? So we have to kind of put it all together. For example, if you're worried about an injury to a vessel, a blood vessel, whether you're worried about an artery or a vein, you will basically, as a radiology resident or as a radiologist, you will have to tell the tech, okay, we want this scan, but we want it in the arterial phase. And what that means is, okay, this needs to be in IV contrast. The patient has to get IV contrast, but we want to capture this image when the contrast is within the artery or within the veins. And the reason is, right, if there's a dye in the artery or within the vein, and if you're worried about injury, if there's a hole in the artery or vein, the dye should leak out and you'll be able to see it, right? So, like, things like that, every patient's diagnosis is different. So you have to kind of evaluate every single patient as to what they would require. Okay. All right. How much patient interaction do you get? So I'm going into IR, interventional radiology, which there's there's a lot of patient interaction. I mean, we had clinic today. We had, it was pretty busy. We had 15 people or so in the afternoon. So we were going in there and seeing patients and kind of examining them and everything. So depending on what field within radiology you go into, you could have a lot of patient interaction, things like IR, things like breast imaging, things like ultrasound. If you go into GI imaging, you're going to be interacting with patients a lot. You're going to be talking to them. You're going to be going, and maybe especially if you're going into, breast and ultrasound imaging, you're going to be talking to the patients. You're going to be going and doing scans on the patients, and then IR, you're always consenting the patients and everything. On the flip side, if you're somebody who, you're a little bit more of an introvert, you like the medicine aspect, you like kind of the idea of solving puzzles and everything, and you kind of just want to work by yourself, you can do that as well in radiology. There are plenty of radiologists who pretty much just, sit at their computer and all they do is they read x-rays, CTs, and MRIs. So there's enough flexibility within the field where you can kind of cater whatever it is that you like doing. Okay. And there are people who will do a little bit of both. For example, my program director, he's trained in interventional radiology. So he does all the IR procedures, but he also reads x-rays. So in between cases, he'll be reading x-rays, CTs, he'll be reading studies. Okay. All right. So let's go through this case real quick, and then we'll answer a few more questions. So normal chest x-ray anatomy, as I was saying, right? So this side, this is the right side. Okay. This is the left side. Okay. And a lot of you guys may have noticed there's this heart-shaped structure called the heart. Okay. And these are the lungs. Okay. The black is representative of air. When you're shooting an x-ray, right, it's basically radiation, a small amount of radiation going through you, or in this case, going through the patient. Things that are not as dense, the radiation beam is going to go right through, and that is going to look black or dark. And things that are a little bit more dense, they're going to show up as white. Okay. So for example, the lungs, they're very spongy. They have to be because we're getting air into them, and the x-ray beam goes right through. So because of that, the x-ray of the lungs, right? Normal lungs, they look pretty dark. Okay. So these are your lungs, right lung, left lung. We mentioned that this is the heart. Okay. This is the quote unquote, the air tube, right? That's the trachea. Okay. And the trachea breaks off into the right mainstem bronchus, the left mainstem bronchus. And basically, those are your air pipes, if you will. Okay. Behind the trachea is your food pipe. You can't see it very well because, usually it's kind of collapsed unless you're eating or drinking something. Okay. Now you may be wondering, what are these thin whitish lines, right? So we already talked about the black. The black is air. We got that. That's lung, right? We got this. This is the heart, right? We talked a little bit about the trachea, right? What are these white lines? Okay. these whitish lines are basically blood vessels within the lungs, okay? Remember, every single organ in the body needs blood. You have to have blood going through to the organ so that it can get nutrients, it can get oxygen. Anytime you have blood not going to an organ, that organ will die. That organ cannot survive, okay? So the lungs, both of them are perfused by blood vessels, and you'll notice it's a little bit darker at the bottom. Not darker, sorry, I should say more dense, meaning more whitish at the bottom. And that's because of gravity, right? Remember, gravity makes things that are, makes things go down. This is our bodies are no different, where it's a little bit more, I guess you could say dense at the bases. There's going to be more blood going to the bases than up top. Okay. And all right. So the vena cava is the, it's basically the vein that brings blood back to the heart. We mentioned that this is the heart, right? This is the right atrium of the heart. Okay. And we mentioned these are the lungs. Okay. And this is important. This is the diaphragm, okay? This right here. This is going to be the diaphragm. And this is basically kind of, you could say, the junction between your chest and your abdomen, okay? Just checking the time. I don't want to keep you guys too late. Okay. All right. So now we get to the case presentation, what we've all been waiting for, okay? Let me see if I can do this. Yeah. All right. So the case presentation. We've got a 72-year-old woman who was admitted to the hospital with acute respiratory failure, okay, meaning difficulty breathing, unable to breathe. She's got a fever, 38 degrees Celsius, which is equivalent to 100.4 degrees, which is what we classify as fever, and dyspnea, meaning shortness of breath, labored breathing. She was tachypnic, meaning she was breathing very quickly, 30 breaths per minute, just for reference. Normal is between 12 to 20, with lymphopenia, and low oxygen saturation. This SpO2 of 85%, that's pretty low. You want your oxygen to be as close to 100% as possible. Anything, 95, 96 or higher is okay. So she's not oxygenating very well. She's having difficulty breathing. She's got a fever, shortness of breath, and she's got some blood markers basically suggesting, I'm not going to tell you because that may give it away. Okay. Now, any thoughts? Now, when I say differential diagnosis, anybody that's a med student understands that. Anybody that's pre-med, you may not understand exactly what that means. When we say differential, we're saying, all right, what do you think is going on? What could be some potential diagnoses? So I'll give you guys, maybe 30 seconds to a minute to think about it. And then, feel free to put your answers in the chat. And I don't expect very many of you to get it. But, all I'm looking for is a thought process. Okay. And as you're thinking about your differentials, you want to think about, okay, what could be something where a patient may have, difficulty breathing. Okay, someone said pneumothorax. Okay, good thought process. Difficulty breathing, low O2 sat. I like that. COVID, yes, very good. Infection, collapsed lung, COPD. Pneumonia, very good. I like the thought of, pneumonia and, okay, asthma. Good. Good. So you guys are thinking along the right lines. You guys are obviously thinking, somebody said bronchitis. Excellent. So you guys are obviously thinking, okay, something's going on in this guy's, this lady's lungs, right? Some sort of disease process, some sort of tumor that is possible. Okay. So let's go through it a little bit more. Blood clot, very good. PE, exactly. That could also be that. These are all part of the differentials. And as you progress through your medical career, it's really important to kind of think about what could be on the differential, right? Meaning what it could possibly be. Yeah, you might be able to get the diagnosis right away, but it's also important to think about what else it could be, because oftentimes it's not exactly clear cut. So you have to be able to think, all right, it could be this, or it could be this, or it could be that. So let's use, our lab work, let's use our imaging, let's try to use all of our tools to kind of narrow down the differential, okay? COPD, sarcoidosis, flu, obstructive pulmonary, COPD, embolism. Great. I love the thought process. Excellent, guys. Okay. So now I'm going to give you a little bit more history. Okay. The patient actually came to the ED 2 days before she was admitted. She had a fever, dry cough, odynophagia, which is difficulty swallowing, and general malaise. I mean, she just generally didn't feel good. And at this point, she wasn't admitted to the hospital. She was discharged. Okay. Does this change your diagnosis or does it not? Do you still have the same thought process? Does it change? I'll give you about 30 seconds to think about it. Okay. If you feel like it's changed, you know, feel free to put something in the chat box and we'll take a look at it. Okay. And as you do that, let me just take this opportunity to, you know, remind you guys that, you know, as you get further along in your, you know, medical careers and you become, you know, med students, residents, and fellows and everything, remember this. Imaging is very important. Don't get me wrong, especially as a radiologist, believe me, I know the importance of imaging, but even more important than imaging is a good history and physical. Okay. You always want to get a good history from people. You know, you really want to find out exactly what it is that's going on. And then you really want to do a good physical exam, because even with all the imaging, if you do a good history and you do a good physical, you'll really be able to kind of narrow it down. Okay. Okay, good. Someone said GERD. Okay. I like that thought process, you know, pneumonia, TB. A lot of people are saying COVID. Okay. Yeah, good. Okay. All right. I like the thought process. Let's go on to some imaging. Okay. All right. So this is that same case that we were talking about earlier. Okay. And I want you to think back a little bit to, you know, a few slides ago. And actually, let me just do this real quick. So look at this, right? And look at what this X-ray looks like of the chest. And then I want you to now take a look at, this is at admission. Okay. I'm gonna let you guys see all the imaging first, and then basically we'll go through the imaging findings. Okay. Here's chest X-ray at admission. Okay. Just absorb it, right? Here's a chest X-ray at 4 hours. Okay. Look at it, think about it. Okay. And we'll look at this again. Okay. But I want you to get the full picture of everything. So this is the patient's chest X-ray at 24 hours. Okay. This is the X-ray at 48. And now this is the X-ray at 72. Okay. All right. So now, right now, if you look at this chest X-ray, right, remember, right, we said that lungs are supposed to be black, right? Because the radiation beam is going right through and the lung is supposed to be very spongy. And, you know, that's why it shows up as black. But if you look at it, someone said fluid in the lungs, very good, right? So you notice that there's something going on in the lungs, right? And we see this whitish kind of hazy opacification. And these are the terms that we use in radiology, right? Hazy opacification, you know, kind of a little bit on the periphery, right? You know, we also see this over here as well on the left side, right? Not only that, right down here, kind of towards the, you could say the right lower lung, right? And remember, this is the right side, this is the left side. It's as if the patient is looking at us, right? And as we progress, right, we're starting to see different things, right? First, it started this way peripherally, right? Now it's kind of a little bit more diffuse, right? And not only that, now we're starting to see these things here, right? Does anybody know what these things might be? These linear looking, you know, you could say radiodense structures. I'll give you a hint. It's not something that is native to our bodies, meaning we're not born with these things. I'll give you about 30 seconds to, you know, put in something. Okay, and as you're doing that, we'll go on to, you know, the next images, because you'll see a little bit more of that. Okay, all right. Now you're getting these, you know, a little bit more, you know, kind of, you could say patchy, or we call it airspace opacities, right? And you see that it's kind of diffuse. Okay. Okay. EKG leads. Okay. Jugular vein. Good. Okay. Scar tissue. Not bad. Not a bad thought process. Okay. Okay, now we'll go on to the 72 hours, and you see, you know, there's fluid in the lungs. There's these opacities kind of throughout the lungs here. You can see that this is kind of, now at this point, it's kind of looking like what we call ARDS, kind of like acute respiratory distress syndrome. Okay, and I'm going to give you a little bit of the findings, right? So you've got, yeah, so at admission, right, there were these bilateral alveolar consolidation with peripheral distribution, right? Now, what exactly does that mean, right? That's a whole lot of mumbo jumbo, right? The alveoli are, when you take a breath in, right, it goes down your windpipe, the trachea, it goes into your bronchi, and eventually it goes all the way down to, you know, kind of the terminal parts of your air tree, okay? The terminal parts are called your alveoli, and that's where the exchange happens, right? Because remember, we take in oxygen, right? And somehow it's got to get into our bloodstream, right? It doesn't magically just happen, right? So it goes in, it goes all the way down to the alveoli, and then through the alveoli, the gas is exchanged, okay? Now, if you have some sort of infectious process or some fluid, sometimes these alveoli can get filled with either bacteria or, you know, a pus. It could be blood, right? It could be fluid. Now, when that happens, you get kind of this pattern, okay? So when we're talking about this ill-defined bilateral alveolar consolidation with peripheral distribution, we're basically saying that this thing right here, this looks like this could be some sort of maybe infectious process, right? And this is where the history comes in, right? If you look at the history and you know she's coughing and you know she has a fever and you know she has difficulty breathing, okay, yeah, we can't definitively say that this is infection. Sure, it could be fluid there too, but based on the history and based on the fact that something is filling in over here, it's probably some sort of infectious process, okay? And a lot of you guys guessed COVID, and I want you guys, and I'm going to show you a little bit more of this later on, what we've started to notice in radiology, because believe me, especially in New York, we saw like countless COVID, you know, x-rays. And what we notice is it does have kind of a peripheral distribution for some reason. Not exactly sure why, but for some reason, a lot of these chest x-rays that come through, they kind of have these, you know, right at the periphery, sometimes bilaterally, sometimes on one side. Initially, it starts there, and then it just goes everywhere in the lungs. It just diffuse. And we see that here too. It starts at the periphery, and then as you go further, 4 hours, 24 hours, 48 hours, it's like everywhere, right? You see all of this stuff all over here. That's not normal, okay? To answer the question that I had previously asked as to what these tubes are, right? So this thing right here is something that we call a central line. It goes in through your jugular vein, and we use that to basically, you can use that to give fluids, or if you need to give like a large amount of medication. It's basically access to the whole body, right? And the way that works is you put it into a vein. Whatever you put into a vein is going to go into the heart, and eventually the heart's going to pump it out to the rest of the body, right? So that's why we do that. Now this thing right here, right? This is actually a breathing tube. Maybe you guys have heard the term intubated, right? That's been all over the news, right? With COVID. What does that mean, intubated? This is what it means. When you put a breathing tube into someone's breathing pipe, the trachea, because they can't breathe on their own. So at that point, what you have to do is you have to ventilate them. You have to basically use a machine to breathe for them. And that's not a good sign. When a patient gets intubated, that means that they're in trouble. That means that they're not able to breathe on their own, and we got to breathe for them. That's really not good. Okay. And yeah, kind of like what we said, I don't want to go too far into it, right? Yeah, we mentioned endotracheal tube and central venous line. This is the breathing tube that we talked about, and this is kind of the fluid tube and the drugs, antibiotics, anything like that that you want to give through there. Okay. Now here's the unfortunate part, right? and this thing, it's a little bit scary because sometimes in people it progresses very quickly. Just 72 hours, 24 hours after that. So what? Four days after the patient was admitted, patient died. Okay. So a couple of more, imaging studies, right? Now, sometimes when it's really early in the disease, and this is why, we have this whole quarantine period, right? Where, they say, oh, if you travel, or if you've been affected, or sorry, not affected, if you've been in contact with anybody who has had COVID or symptoms of COVID, you got to quarantine for 14 days, right? What's the reasoning? The reasoning is initially it may not show up. It may not show up on x-ray. You may not have symptoms. It doesn't mean you don't have it, right? So for example, right? So this is someone who basically presented and didn't have any overt signs, but it was kind of just having like, a little bit of shortness of breath. And if you look at the chest x-ray, it really doesn't look too bad, right? If you look at it, it's very subtle here, right? It's very subtle. It's a little bit more opacified in the right lower lung compared to the left lower lung. But honestly, the rest of the lung doesn't look too bad. Looking at this, I would maybe question it. You know what I mean? Maybe say that this is a little bit more opacified than on the left. But it would be very difficult to just come down hard and say, oh yeah, this is definitely COVID, right? Now, and this is a great example of the difference between an X-ray and a CT. Here's your X-ray, right? You can see it okay. You can maybe make it out, right? And now you look at your CT on lung windows, man, you can really see these lungs like super clear. And you can see this COVID, this infectious process kind of brewing here, right? And you can see it much more clear on CT than you can on X-ray, because, when you look at this, right, where the red arrows are pointing, you see this on this side, on the right, but you don't see that on the left. This costophrenic angle, it's pretty sharp. There's nothing going on there. It's black. Right? So CT, the benefits are that, things appear much more clear. The drawbacks, it is very, it's heavier with the radiation. Okay. All right. I want to give you a little bit more. Okay. So this is somebody who also has COVID, and I want to show you like the progression, right? 4 days later. Okay. And all they didn't get a CT. They got a chest x-ray on the first day, and they would get a chest x-ray every single day. Okay. And this is the 4th day. And you can, even if you're not a radiologist, you can tell. Obviously, if you're a radiologist, we follow this every day, and we can tell the subtle differences and everything, but you can see clearly that there may be a little bit on the periphery. There's a little bit of opacification here, but here it's like, man, it's really, a lot of consolidation there and everything. Okay. And at this point, right, it's got a breathing tube, it's got a central line. Once you start seeing these things, it's not a good sign for the patient. Okay. And actually just a random, point of note at my hospital, and, in many hospitals, actually, we changed our way of thinking. Meaning before it was, all right, if a patient gets into the 80s, right, we got to intubate, right? That's too low. We changed our way of thinking because we realized once you start intubating patients, they don't do very well. It's very hard for them to come back. So what we decided is, let's try to hold off as long as possible to give these patients a fighting chance. Okay. And, I think it saved a lot of people in the long run. But anyway, that's me going off on a tangent. All right. Another case. Okay. This is an 83-year-old male with mitral insufficiency. Okay. That's one of the valves in your heart. Okay. Pulmonary hypertension and atrial fibrillation with COVID-19. Okay. And I'm not going to go too far into the hard stuff or the pulmonary hypertension, because, we could talk about that for a whole nother hour. But looking at this, right, this is what I was talking about before, the peripheral consolidation. Okay. Peripheral opacification over here. Okay. This is kind of like what you would see. Okay. All right. And a lot of these images I got from Radiology Assistant, which is a wonderful website, which, if you're interested in radiology, I would definitely recommend looking at it. They have a lot of images. It's very user-friendly and everything. Okay. Any questions? Any questions about anything? I think, you know, because we started a little bit late, we still have, you know, a few minutes. You know, feel free to, you know, drop them in the chat, and, you know, we'll address them as they come in. Okay. The other thing I just wanted to mention about radiology is that, you know, at least at my institution, every week we're kind of doing something different. You know, for example, you may be on mammography one week, excuse me, and then you may be on, you know, ER x-rays the next week. The week after that, you might be on CT scans. The week after that, you might be on neuro. You know, neuroimaging would be, you know, anything related to the head, the brain, you know, the spine, yeah, you know, head and neck area. Okay. So there's a lot of, you know, there's a lot of variety within radiology. Okay. So, you know, if we'll give it a couple more minutes if there are any other questions, but okay. And here's my contact information. If you are interested in radiology, if you want to learn about interventional radiology or diagnostic radiology, you know, feel free to, you know, hit me up on Instagram. It's at @UsadBaigMD. I'm on TikTok. I'm not very good at TikTok. I got to be honest. And you know, if you have kind of a longer question, you know, you can email me. I do take a little bit longer to respond on email. I have to be 100% honest. Instagram, I'm usually pretty good at, you know, responding right away. All right. How many COVID cases do you see in a day? So let me give you a little bit of, you know, if you're from New York, you kind of already know this story. So just bear with me for a minute. For those of you that are not in New York, that may be getting hit hard with it, in March, April, and May, we were hit so hard with COVID that they were taking radiology residents. I was on the floor. I was doing internal medicine stuff because there were so many COVID patients. Our entire hospital was COVID. And we weren't even the worst. There were hospitals, you know, in other parts of, you know, New York and in the city, that were just getting even further destroyed. So we used to see tremendous amount. Our pretty much our whole hospital was COVID at one point. Now, you know, because of masking, social distancing, you know, all that good stuff, our COVID cases have gone down so much, to the point where, you know, it was a handful of people in the hospital. It's gotten a little bit more since school started and college started and everything. It has gone up a little bit. I'm hoping that it doesn't really go up too far, but these days, you know, maybe 10 cases, 15 cases or so, it's really not too bad still. I'm hoping that it stays like that, but we'll see. Why does intubation end up doing worse for their recovery? You know, we're not entirely sure exactly why, but what we found is that when patients are forced to breathe on their own and kind of expand their lungs on their own, and this may be related to that, they end up doing better. We've had to do, you know, different things. We've done something like, we call it proning the patient, where, you know, basically we put them on their belly. The reason being, if you look at the lungs, there's more surface area in the back of the lungs, in the posterior section of the lungs. So if you put the patient on their belly, basically what you're doing is you're allowing more of the lungs to kind of be aerated, to be oxygenated. The biggest thing with COVID is just getting patients oxygen as much as possible. And if you can expand the lungs and get more oxygen in there, you know, that we found basically helps for recovery. Okay. How competitive is it to get into radiology resident? Radiology is pretty competitive. It's not the most competitive, but it's up there. Interventional radiology is one of the most competitive, you know, fields to get into right now. Radiology is pretty competitive, but it's not impossible. You know, what we're looking for mostly is, you know, and as a chief resident, I can tell you this, because what we look for in our program is, you know, decent scores. You know, if you have astronomical scores, great. If you don't, that's okay too, as long as you have decent scores and, you know, you have a good attitude, you're coachable, you're a nice person, we'd like to work with you. These are big things that we look for in radiology. Okay. Do you need to be good at physics to get into radiology? No, I am, I am not the best at physics. Let me just put it that way. We do have to know it for our boards, because you do have to understand kind of the basics of how an MRI machine works, how a CT scanner works, how an ultrasound works, how the images, how you're getting the images. So you do have to understand the physics of that a little bit, but you don't have to know, like, you know, F equals mv, right? Or F equals ma, force equals mass times acceleration. You don't need to know those things that we have to learn in college and high school and everything. Okay. What other specialties were you considering before committing to radiology? I actually thought I was going to be a surgeon, believe it or not. Initially, I thought I was either going to go into orthopedic surgery or general surgery. And that's what I had initially applied for. But, you know, when I got exposed to radiology and, you know, I was lucky, I had a mentor who really kind of, you know, encouraged me to look into what interventional radiology was. When I found out about interventional radiology, I said, man, you know, I would like to do this. So when that happened, I kind of switched into radiology. Okay. Have patients ever reported complications with the radiations or dye used in interventional radiology? How would you measure, if any, about the radiation risk? Great questions. Okay. Regarding the dye that we use in interventional radiology. So if there's any patient that has a documented allergy to the dye, to the contrast, we have to do what's called pre-medication, meaning before they're able to get a scan, they have to get medicated by certain, you know, medications that will prevent the allergic reaction from happening if the study is absolutely necessary. Now, this is also where protocoling comes in, right? If somebody has an allergy, there are other imaging studies that you can potentially get. And this is where you would call the radiologist and say, hey, look, I'm thinking about this diagnosis. This patient has an allergy to this contrast. What else can we do? Okay. And we work with them, and we work with, you know, the different departments to kind of figure out what we can do for this patient given the limitations. Okay. And if you have a complication, you know, we are trained to basically deal with the complications. Every institution has a protocol for what happens if there is a reaction to the dye, to the contrast. And, you know, in a hospital, there are always residents, there are always people, you know, kind of working. So there's always going to be somebody there to kind of be available for patients if, God forbid, something like that happens. How would you measure, if any, about the radiation risk? We actually have to wear radiation markers. We have to wear tags, you know, and that basically kind of measures how much radiation we're exposed to. And every month we have to exchange it, where we give it to kind of our program, you know, radiation coordinator, and in my program, you know, she takes it, she gives us a new one, and they measure how much radiation we're exposed to. So if there's ever any spike in radiation, you know, they'll contact us and say, hey, you're getting too much exposure to radiation, like stop. Okay. All right. So that's how it's measured. Have I gotten COVID myself? If not, have you stayed protected? I have not, you know, that I know of. To be honest, I have not gotten the swab tested yet. Yeah, you know, I've been very lucky in that I have had PPE when I've gone to the floors. I think I posted this on my Instagram, like a picture of me, like in my face shield, and I had the spacesuit and everything. And I say I'm lucky because I know there was a big shortage and not everybody had that. So I feel very blessed that I was able to have, you know, kind of these protections and everything, and masks and everything. Okay. What do you love most about radiology, and what's the most challenging part of the job? I love the fact that you're involved with every single process, right? And specifically about interventional radiology, you have the ability to do diagnostic radiology and interventional radiology. Diagnostic radiology, you're diagnosing patients, right? Patients are getting scans, and they're basically kind of depending on you to tell them, all right, what is going on inside this person's body? So I really like that aspect. And it's almost like you're kind of solving a puzzle, right? You're trying to figure out what's going on with this patient, right? I'm looking at the imaging and I have to find what's wrong. So that part I think is really cool. Interventional radiology, you get to do that. And then also you get to kind of fix it, right? If you see something that you say, oh, okay, it looks like there's a little bleed right here, you can actually go and fix that in interventional radiology. Or, oh, I see this mass right here. I see this lymph node. Oh, I'm an interventional radiologist. I can go and do a biopsy and we can find out exactly what that is. So that's what I really love about radiology. One of the most challenging parts, though, is, you know, you're very dependent on other fields to give you history. In interventional radiology, it's a little bit less because you do go and see patients more and you're going to do your own physical and everything. But if you're just doing diagnostics and you're someone who's just, you know, in a room reading, you're very reliant on the clinicians and their history. You know, you're reliant on the ED, internal medicine, because you yourself, you're not necessarily doing the physical, but you're kind of relying on them. So that's kind of a little bit challenging to put it all together, because remember, it's a puzzle, right? So you have to put it all together. Okay. How much calculus do you use in radiology? None. I have not used, I don't think I've used calculus after I took it my sophomore year of college or freshman year of college. Best advice for pre-med students: work hard. Obviously, try to keep your GPA solid. Try to do well on the MCAT. And if you don't, that's okay. You know what I mean? You're just gonna have to work a little bit harder. But if you're willing to put in the work, I know plenty of people, and believe me, I did not have a stellar GPA. I did not have a stellar MCAT. I was basically a little bit above average. You know what I mean? Nothing crazy. But there are people who are a little bit below average that end up getting into medical school and do fine. But they just had to work a little bit harder. And if you're willing to put in that work, as a pre-med, you're going to be just fine. And keep a good attitude. You know what I mean? If you have a good attitude, that's infectious. People want to work with people that have a good attitude. Okay. Do you work with all ages? Yes. That's one thing I forgot to mention. There is a field within radiology called pediatric radiology. You know, as when you're a board certified radiologist, yes, you can read images for every, you know, for every age. Some students want clarification on diagnosis. Sorry, I just saw that pop up. It was COVID. It was COVID-19. All of those cases were COVID-19 cases. Every case that I showed you today, besides a normal chest x-ray. Okay. But as I was saying, yeah, we work with, you know, all ages. There are people who just really like pediatrics and they'll specialize in that. They'll do a fellowship in pediatric radiology. One of my classmates, he's going to do a fellowship in, you know, pediatric radiology. And then there are people who like doing all ages, and they'll do pediatrics, they'll do elderly people, they'll do young people. But yeah, so we work with everybody. All right. Would you say as an interventional radiologist, you work with surgeons mostly? The thing about IR is that we work with everybody. Our referrals come from, we actually work a lot with oncology, interestingly. You know, we do a lot of stuff with cancer. We do a lot of biopsies. We do a lot of, you know, tumor ablations, tumor embolization. These are both fancy ways of saying ways to either shrink the tumor or kill the tumor. So, you know, we'll do that. You know, we do that on the oncology side. Today I saw a patient that, you know, it was a woman who had very, you know, heavy periods and was having like a lot of pain with her periods because she had fibroids. We do procedures to basically shrink the fibroids. So we work with GYN. So, you know, with IR, you're basically working with kind of every field. The surgery team, they referred a patient to us today for a PICC line. You know, we work a lot with nephrology if they need, you know, like nephrostomy tubes or something like that, you know, if there's something going on with the kidneys. So we're kind of like all over the place, you know, with every single department we interact with them. Yeah, you know, that's what's kind of cool about IR. All right, let's see what else. Tips for MCAT. I'm a high school senior applying to schools right now for pre-med / biochem. Okay. So first of all, good luck on your MCAT. Second of all, I would say, you know, the biggest thing that I think people have told me is that practice questions. Okay. Make sure that yes, you have your base of knowledge, but remember, right? The MCAT is not necessarily a knowledge test. You do need to have a base of knowledge, but it's a questions thing, right? You got to know how they're going to ask the questions. You got to know that, all right, they're going to give me a bunch of information and then they're going to be like, all right, extract from this information, you know, some knowledge so you can answer these questions. And, you know, that's not going to change. That's not going to change when you take, you know, your step 1, your step 2, your step 3, your radiology boards, your internal medicine boards, like whatever field you go into, practice questions. Do them, learn from your mistakes that you make on them, right? Just because you do them doesn't mean like, oh, okay, I did them, I'm good. Nah, you gotta basically do the questions, read the explanations, take notes if you can. Okay. Yeah. All right. How do you see artificial intelligence impacting work in radiology? Is it something that those entering medicine should be concerned about? I would say yes and no. Obviously, with AI, it can impact many fields, radiology especially, right? Because theoretically, if you can teach a resident, you can teach a machine, right? They say we're not too far off of machines in terms of our intelligence. No, I'm kidding. Yeah, the thing about AI is that it's very good at certain things, but at the end of the day, you got to think about it like me as a patient, right? What would I want, right? Sure, would I be okay with a machine reading it? Yeah, but I think I would still want, like a radiologist to just look over it. So the way that I think it's going to work is that I think AI will be a part of radiology, meaning it will be used to kind of stratify what are important studies and what are kind of, sorry, I shouldn't say important, what are urgent studies, meaning what are urgent findings that somebody needs to look at right away. And with that, I think there's a big application for that. There's also the legal aspect. You have to consider this, right? If you only have machines reading these x-rays, who, I hate to say it this way, but who are the lawyers going to sue? The machine? Like, unfortunately, for better or for worse, right? The lawyers, they want to hold somebody responsible. And for that, that's one of the reasons that I don't think that radiology jobs are going to go away. They were saying for the last 20 years that, radiology is going to be outsourced to, China and India and whatever. And, all the radiologists are going to lose their jobs. I mean, believe me, they were saying this when I was in college, I would say, don't go into something or don't not go into something because you're worried that, AI may or may not take over. I would, obviously read about it beforehand, but I'm not that worried. All right. How do you deal with off days? What do you mean how I deal with off days? I chill, does that mean off days like days off, or does that mean like days where I'm not feeling well? Because if it's days off, I basically chill, I'll study, hang out with friends. That's the other thing that's nice about radiology. You actually have time to do that. Dealing with off days, if you're not feeling well, it's really program dependent. Luckily, my program is very supportive. If you're not feeling well, if you're sick or whatever, we basically have kind of unlimited sick days. If you're not feeling well, somebody will cover for you. If you have to go to the doctor, you can go to the doctor, just bring in the doctors. No, not a big deal. All right. And dealing with days when you don't feel good, I kind of just try to tough through it. And, I try to remind myself also, like, this is a position that I would have killed to be in. I'm in my final year of residency, which, radiology is a total of 5 years. I would have killed to be in this position, 5 years ago, so I think about that, and I say, yeah, maybe it's a rough day, but all things considered, like, I'm good, Do getting x-rays affect those that are going through chemo? No, it does not. How is your residency structured? The way that residency is structured is your first year, you're going to do either internal medicine, surgery, or transitional years. Some people do pediatrics. And then the next 4 years, you'll do radiology. The way it works is your first year, you're going to be a little bit heavier on x-rays and, neuroimaging, because those are kind of basics that you have to get down. And then as you progress, when you go towards the end of first year, second year, third year, and fourth year, you're going to be doing higher level imaging. You'll be doing CTs, you'll be doing MRIs, you'll be doing more of that stuff. And, in your final year, you're kind of, you, at least in my program, you can kind of tailor your schedule to what you want to go into. So I'm going into IR. So I'm doing a lot more weeks of IR. There's one of my classmates, she's going into mammography. So she's got more mammo. One of my classmates going into pediatrics, so he's got more weeks of peds. So you can kind of structure your final year the way you want it to be. Work-life balance is good for interventional radiology. Got to be honest with you, it's good. It's not as good as diagnostic radiology. Diagnostic radiologists, in my opinion, have the best work-life balance. Interventional radiology is somewhere in between diagnostic radiology and surgery in terms of work-life balance. Most IRs that I know work something like, maybe 7:30 in the morning to, 4:30 or 5, So it's not a super long day, but it's also not 9 to 5, which is mostly what diagnostic radiologists work. Okay. Tips for time management as a pre-med. This is probably the hardest thing. And I don't want to be a hypocrite because I have to admit that I am a procrastinator and I'm working on getting better. But the biggest thing that I've learned is that if you make a plan, try to stick to the plan and try to plan ahead. What I'm doing for my boards now is I made a schedule. I wrote it down. Writing it down is huge. If you write it down, you hold yourself accountable. And basically you're like, all right, I wrote this down. Now I'm going to try to do it. I'm going to try to cross it off the list. Okay. If you start writing down your goals and start checking things off as you do them, I guarantee that, you will, in my opinion, you'll probably find that you're getting more stuff done. Okay. And plan ahead. There's a saying that goes, failing to plan is planning to fail. Okay. All right. How much time do you spend with patients? It depends. It really depends on the patient. There are certain cancer patients who have, for example, liver cancer. And, when we do a procedure where we'll basically kind of either basically, to make a long story short, kind of shrink the tumor or get rid of the tumor, that sometimes with those patients, we have to spend 30, 40 minutes with them kind of explaining what the procedure is, going through the imaging, doing, getting a history, doing a physical. And then there are certain patients where it's just a follow-up for maybe a procedure that we've done where we'll spend maybe just 10 or 15 minutes with the patient, just see how they're doing, and that's that, right? So it's really variable. Okay. What other specialty would you have chosen other than radiology? Like I said before, I was originally thinking about surgery. I actually did a year of surgery and I enjoyed it quite a bit, but I think that IR and radiology was better suited for me. Okay. What'd you do during your pre-med years in terms of clinical hour research? I did a decent amount of research, I will say. And I think it's important to get started early with research. Clinical hours, I did shadow some doctors, which, by the way, shout out to web shadowers. If you're on this chat, you're getting your hours and everything, and you're doing the right thing. You're getting exposed, and this is something that you can put on your resume. Okay. Yeah, so that's what I would do in terms of clinical hours. Shadow, find a mentor. Even if you have to cold email, I'm gonna say let's wrap up if you don't mind, because it's almost 9 o'clock on the East Coast, and I still I haven't eaten anything all day, so I want to get some grub in me. Yeah, so for clinical hours and research, I would just, even if you have to just cold email people, do it. But don't, let me give you this advice. When you cold email people, right, you want to address them. You want to write their name correctly. You want to start with something like "Hope all is well," and then introduce yourself. Because if you're cold emailing somebody, they don't know who you are. Introduce yourself, and then also say, like, I'm very interested in your research regarding blank, right? You want to show that, all right, I want to do research with you, but I'm not just like saying I want to do research. I actually read a little bit about what you're doing. And this will basically say, all right, I think we're getting some echo, but this will basically tell that person, like, okay, this kid, this student actually wants to do this research with me. Let me actually open the email. And don't be discouraged if you don't get a response. If you email 100 people, only expect 5 responses back. And if you email 100 people and you get 5 responses back, that's amazing, because all you need is just one. You just need one mentor that will basically help you get into research. Okay. So I would say that. And clinical hours, we talked about shadowing, volunteer at hospitals if you can. That's good for that. Okay. And that's it. Is there any radiology specialties that perform procedures besides IR? Very, very good question. Yes. Mammography. You do breast biopsies like all the time. There are body imagers, people who do fellowships in body imaging who will also do specific procedures related to the body, things like biopsies, things like, basically abscess drainages. So you will do that. Neuroradiologists, they'll do a lot of, like we're doing a lumbar puncture tomorrow, actually. Lumbar puncture, you could do kyphoplasties either as IR or neuro. For sometimes neurointerventionalists, as if a patient has a stroke, you can go up into the brain and grab the clot and pull it out. So most, and even musculoskeletal imaging, like all that stuff, if you have kind of calcifications within your shoulder, that's stuff that, a radiologist would do, breaking up the calcifications, knee injections, hip aspirations, like a musculoskeletal radiologist would do this. So radiology is much more than just looking at images. Yes, it is looking at images. That's the core of it, but there are multiple fields in which you would do procedures. Okay. So that's all I got for now. I don't know if you guys want to take over, but thank you guys so much. And let me just, they wanted me to put a motivational quote or something. So just work hard, have a good attitude, and praise God. Be thankful for everything that you've got. And then, like I said before, this is my contact information. Please don't be shy. Reach out. There's only one person that I still have to respond to. He asked a lot of questions, so I said I was going to give him a voice message. But if you send me a message, I will respond to you. All right.
Thank you so much, Dr. Baig. This was such an awesome session and very interesting to learn. We all appreciate you so much. Everyone, make sure you check it out, his socials. His Instagram is @BaigMD.
Perfect. Thanks, guys. Alrighty, take care.
Again, we want to remind all of you that tomorrow the monthly roundup for September will begin at 11:59 p.m. EST and it'll close Sunday 11:59 p.m. EST. This means that the forums will be opening back up and you will be able to watch any posted live streams of the month of September that you did not attend live, and you will also be able to fill out the forms to earn credit.
Remember that this is completely optional and just a way to allow you guys to get more hours. Please do not refill the forms that you have previously submitted before. Additionally, we will have a document posted on our website and on our Instagram that includes every link.
Again, thank you so much, Dr. Baig. This was an awesome presentation, and thank you all for attending. The link to the Google form has now been posted in the comments, and it will soon be in our Instagram bio. So please fill it out within the next 30 minutes.
Thank you so much, Dr. Baig. Everyone loved you.
Have a good night, guys. Take care.